My name is Sohier Elneil, or Susie Elneil, as most people know me, and I was very fortunate that several colleagues had agreed to collaborate to help us with this workshop. And I'll start off with the first talk this afternoon, which is the epidemiology, and then I've got my other colleagues talking basically about management of fistula, particularly after there's been primary repair and all the issues that arise from that. So the role of investigation, the role of physiotherapy, the role of reconstructive complex surgery, what possible complications can arise, and so on. So we are trying to approach it in a multidisciplinary way, but equally importantly, approach it in a way to answer some of the questions, hopefully, that we always find difficult to answer in this group of patients. Okay. So the main etiology, particularly in the world globally, if you look at any form of fistula, is obstetric injury. With these sort of maternal mortality rates that you can see in this slide, most of us are aware that it's a high mortality rate that is present, but perhaps more importantly is that for every woman that dies, we believe 20 will have a chronic and crippling morbidity. However, this is truly a ballpark estimate. It is not a figure that has been worked out using anything other clever, nothing more clever than the people actually working on the ground and making that estimate. If you look at the scope of the problem, although you can go all the way from things like pain up to complex genital tract fistula, increasingly those of us working in the field are fully aware of the role of mental health problems and the impact of psychology on these women and the role of domestic violence, because a lot of these women and sometimes children have been put in a very difficult situation which of significant compromise. So although genital tract fistulas are towards the end of our complex of symptoms, you have to look at almost all of this intact with this, in tandem with this, as well as with these aspects. So in the developing world, there is a sort of 8% risk of you developing a fistula from obstructed labor, from traditional practices, war-related injuries, and that's very much country dependent. So certain countries will have a higher rate of this than others, but the vast majority still remain in obstructed labor. If you look at the pelvis, and this is a slide I use often, showing the impact of the fetal head sitting down there. Now, as long as the process completes nicely and the head comes out, and you get proper skin and vaginal soft tissue dilatation to allow the process, you usually are fine. However, if you have this head, which is quite a hard structure, impacted in the pelvis, sometimes days on end, you can see not only do you end up with trauma in this area, or there might be actually extensive trauma to the bony structures and the neurological aspects as well. So the nerve structures at the back, particularly the sacral nerves, tracking down into the limbs. And when my colleagues speak, you will see some of those complications. Pelvic floor anatomy, and this is a sort of a basic picture, really essentially showing that the impact of the fetal head directly on all these organs can result in any of them becoming ischemic and causing long-term problems. And this is just to show you the fact that if you've got a baby's head coming out through here, the impact on your continence support structures, pelvic organ support structures, as well as the functionality of the vagina are all affected, if not badly traumatized. In the developed world, it's much more likely that you'll get a fistula, significantly less risk, with surgical trauma. There's still some obstetric trauma, but foreign body trauma, malignancy and radiotherapy. And certainly in my practice in the UK, I see a lot of patients after surgical trauma, particularly after hysterectomies, and some after foreign body trauma. So if you look at all the factors, and we have no exact figures, but there's a 100-fold disparity between maternal mortality ratios in the developed world versus the developing world, and 99% of all maternal deaths are in the developing countries. If you look at some of the stats that have come at us from various groups, you can see that particularly if you're looking at Africa, the disparity between Africa and Southeast Asia and going all the way up to the higher income countries shows you that there's a huge problem in this continent. And you can see it doesn't affect just all the expected diseases that you'd expect in a developing setting, but equally other conditions as well. If you then look at death rates due to injury in women of the reproductive age, you can see that actually it's quite high in Southeast Asia and parts of Africa and the Eastern Mediterranean. But what's quite dramatic here, if you're looking at all the amounts of the problem areas, you can see that particularly in Africa, you're dealing with violence and war predominantly. Suicide is a factor, but also other unintentional injuries. So it's a huge gap and a huge area that has not been addressed in both sort of domains, Southeast Asia and Africa. So the main focus in the literature remains mortality, but morbidity is not a health denominator, so it's not reported. And that's one of the biggest issues we have to fight, in that in the World Health Organization, everything that is assessed has to have a denominator and has to have a reportability. So we all report mortality, but nobody reports morbidity. It is changing, but it's still not changed. So we don't know the true extent of morbidity in our patient group. If you look at some of the factors here, with morbidity versus mortality, you can see that the ratio is extremely high in a lot of countries. There's some nice studies coming out, and this is from Tanzania, looking at the impact of what makes a woman ill, basically. And basically, if you look at the different parameters here, so they're classed as D1, failure of the woman or family to recognize the delivery problem, and D2, the failure of the traditional birth attendant to recognize the problem, you can see the impact on the entire community is a whole series of events. So these are some of the stats that we've got written in the literature. So in 1993, it was thought there were 2 million women, and in 2004, they reported 130,000 new cases per year. Again, ballpark figures. So what is the real problem? Well, if you have 7 million obstructed labor problems, and therefore 2% develop a genital tract fistula, that makes that 130,000 cases per year. But if you go to country by country and you look at all the aspects, actually some of those figures may be way off in a higher sense or in a lower sense. So we've gone to some countries, particularly in East Africa, where we think the numbers may be slightly less than this, but in fact it's still not proven. So yet again, we have to keep an eye out for this. The one thing that we know is that if you get a reduction in your maternal mortality, you often get a response in the maternal morbidity. So things improve generally all round. If you then look at the obstetric fistula pathway, which was developed by the Worldwide Fistula Fund, it is quite a complex pathway, but the whole purpose of it is really looking towards improving and preventing obstructed labor to stop this whole process from taking place. These are the geography here of most of sub-Saharan Africa, and it's known really as the home of vesicovaginal fistula and rectovaginal fistula. What's important about this picture is perhaps that also female genital mutilation is as prevalent in these countries. So many campaigns have been started, and this was by the United Nations Population Fund, the UNFPA, looking first of all at which countries had a problem, and you can see the problem is predominantly sub-Saharan Africa and parts of Asia. They then developed a sort of phased development of fistula services, looking, sorry about this, it keeps jumping, looking at a development of process. So phase 1, looking at the assessment of need. Phase 2, looking at interventional planning, and phase 3, commencement of a strategic input. And this is, as you can see, over a period of time, progressively moves through the different countries. The current situation is that we tend to look towards two areas. One is the surgical correction of fistula, and the other is the prevention of obstructed labor. The big problem with obstructed labor, of course, is the fact that you are dealing with not just the labor process in a single woman, but a whole system in the whole country, and how do you correct that and make it better. So the results are understandably variable, the clinical outcomes are also variable, and of course, for many years there was no standardization in the process of doing the fistula surgery. This is just to give you an idea of all the different aspects of the campaign and different milestones done by the UNFPA, and you can see quite a lot of discussion. And indeed, next week, the UNFPA is holding its latest meeting in Uganda, Kampala, looking specifically at the work they've done so far, because it's now well over 10 years, and looking at how much further they can improve uptake of better maternal health. So the International Obstetric Fistula Working Group, which Professor Murad, who's here with us, is also a member of, really looked at establishing a way that we could all speak to each other, because it was a very disparate group and many people were doing many different things in different places, but nobody was having joined up thinking. So there were 4 committees established on policy and advocacy, treatment and training, reintegration, and research. So where are we in the developing world? Well, there's a huge request for investigative resources and a need for a lot of other input. But why are we failing, or why have we failed? Originally, it was because of poor communication, the political issues and financial, and then, of course, corporate responsibility and encouragement and empowerment of individuals and nations. So it's a sort of slightly bizarre mix of things, but all needed to be fixed to some extent in order that you could actually come back to this, which is improve all of these things that were requested and needed. So certain groups came together. One was the FIGO and Partners group, which was to look at improving surgical management and developing a unified and objective evidence-based approach to surgery. It was quite a complex group of people. Surgeons at the best of times are not very easy to work with when you have a group. And so it really required a lot of people coming together, work and determinedly working together, but most importantly to focus on the field-dedicated surgeon and to empower them and provide advocacy. This is the actual manual, and you can actually access it directly from the website. You don't need any special login or anything. So this is just to sort of bring you up to speed, looking at how we're going to improve things in the long term, and we hope to improve things in the long term. And just to give you some idea of the background problem that we're dealing with. We are obviously now trying to work with our colleagues in the Education Committee to bring in not all the aspects of the management of fistula, but also to look at prevention principles and working with other colleagues in different arenas in the developing world and elsewhere to improve our uptake of prevention and hopefully reduce the impact of bad labor management on the pelvic floor. So for the rest of the talk this afternoon, we're going to go with Professor Murad, who will be talking about what's going on in the developing world, including the anatomy and classification, and then Professor Christopher Payne, who will be talking to us about complications. We'll have a few questions and then a break. And because I'm conscious that some of you might like to catch the 6 o'clock bus back home, we will try and finish before 6 if we can. So we might shorten the break and then carry on with the rest of the talks after our break time. So without further ado, I'd like to ask Professor Murad to come forward and speak to us about the next thing. Thank you.